Thank you, Dr. Murgas, for inviting me to this wonderful conference, and I really appreciate being here. I'm going to be speaking this morning about neonatal encephalopathy and hypoxic ischemic encephalopathy and the diagnosis and management. We're going to start with a case. Baby girl F was born to a 35-year-old G5-P4 mother, good antenatal care. This pregnancy was complicated by gestational diabetes, which was diet-controlled, preeclampsia, and obesity. Her laboratories were non-contributory, they were all negative, and the mother was admitted at 37 plus 2 weeks with active vaginal bleeding. The ultrasound showed a severe placental abruption, and the fetal heart tones showed severe variable decelerations and bradycardia to the 50s. The C-section took 10 minutes due to the maternal obesity. So the pediatric team was called to the delivery room emergently. The baby was delivered by an emergency C-section. At delivery, she was floppy with no respiratory effort and no heart rate. The bag mask ventilation was started immediately. The heart rate was noted to be above 100 at 5 minutes, with some gasping respiratory effort noted at 6 minutes. She was intubated at 7 minutes for poor sustained respiration, obviously a little difficult to intubate her. The color improved, but she remained floppy at 10 minutes. So the APGAR score was 0, 4, and 5. So the first question is, what do you ask the obstetrical and labor and delivery staff in the delivery room? First of all, you should think to ask them to send the cord blood gas. They did, and the cord arterial gas was 6.8, the PCO2 was 103, the PiCarb was 15, and the base deficit was minus 19.7. So for sure, if you get this result, you would be very concerned about this baby. The cord blood gas provides critical information regarding the severity and the duration of hypoxic ischemic insults prior to delivery. And the cord arterial gas from the umbilical arterial side is a part of the criteria for the hypothermia treatment, so it is important to get this information. If you cannot get a cord blood gas, or if it's not available, make sure that you get an infant arterial blood gas within the first hour of life. You proceed to do a physical examination. The weight, the head circumference, and the length are all greater than the 90th percentile. The temperature is 36.5. The heart rate is 190. The blood pressure is low at 37/23. The baby is pale and poorly perfused, is now on the ventilator with periodic respiratory effort, but there are no significant dysmorphic features. So you want to know, does this infant display an encephalopathy? And how should the neurological examination be done or documented to show this? So the HIE criteria are based on the Sarnat staging, which is from the 1970s. And Sarnat divided the stages into stage 1, 2, and 3, 3 being the most severe. We know that most of the babies with stage 1 have no long-term morbidity or no significant mortality. So we worry the most about the babies in stage 2 and stage 3. So from the NIH, the NICHD exam criteria to determine whether a baby can participate in hypothermia, we do a careful neurological exam to determine if there is moderate or severe encephalopathy. And this should be carefully documented in your record to determine the stages that the baby is in. So first we look at the level of consciousness. Is the baby lethargic, which would be moderate, or is the baby in a coma, which would be in severe encephalopathy? Next, looking at activity, is there decreased activity but some movement or no movement at all? In terms of the posture of the baby, is there distal flexion or is the baby decerebrate? Looking at tone, is there decreased tone, hypotonia, or is the baby totally flaccid? We next look at the primitive reflexes, 2 of them. We look at a suck reflex, is it weak or is it totally absent? In the Moro reflex, is it incomplete or totally absent? Finally, evaluating the autonomic system, looking at 3 features. Are the pupils constricted or fixed and unequal? Is the heart rate bradycardic or a variable heart rate? And in terms of respiration, is there some respiration or the baby is apneic? So it is important each time to look at all 6 of these features. So on your baby that you have in your unit, you did a detailed systematic neurological exam and you documented that the level of consciousness, there was poor eye-opening to stimulation, no sustained alertness, minimal spontaneous activity with hypotonia. The pupils were constricted but were reactive. There was no suck or gag. There was an incomplete Moro and no deep tendon reflexes. So looking at the lab work, what is the lab work that you need to get immediately to help you manage this patient? So which of these things would you do? Would you get a blood glucose? Would you get a complete blood count? Would you get a blood culture, electrolytes, BUN, creatinine, liver function studies, or coagulation tests? Think about which one of these you would do. The answer is you would do all of them. You want to correct hypoglycemia, as significant hypoglycemia is critical for brain protection, and correcting that is important. The mother had a placental abruption, so hematocrit and platelet count will help to determine if the blood product transfusion is needed. And looking at a creatinine, you can already tell if there is kidney injury, and the LFTs and coagulopathy will determine if there is liver damage. So the results now that you obtain are a pH of 7.01, PCO2 of 94, bicarb of 12, and staying at -19. The blood glucose is only 15, the CBC is 17.7, a slightly low hematocrit, a fairly normal platelet count. The creatinine is pretty reasonable at 0.8, but the liver studies are already elevated at 945 and 220, and there is evidence for a coagulopathy. So what to do now? What is your diagnosis? This baby demonstrates severe encephalopathy, and we can assume it is due to hypoxic ischemic encephalopathy from the perinatal events. So now what is your management? How can you preserve the brain function and improve the survival and the morbidity of this baby? What is most important at this point, in addition to the routine management, is body or head cooling. Let me first go through some definitions, since there is a lot of confusion about neonatal encephalopathy and a component of that, hypoxic ischemic encephalopathy. Hypoxia or anoxia is a partial or complete lack of oxygen in the brain or blood. Asphyxia is the state in which the placental or pulmonary gas exchange is compromised or ceases altogether. Ischemia is the reduction or cessation of blood flow to an organ which compromises both oxygen and substrate delivery to the tissue. And the definition of hypoxic ischemic encephalopathy is an abnormal neurologic behavior in the neonatal period arising as a result of a hypoxic ischemic event. But as we know, the majority of encephalopathy that is seen in neonates and infants is not necessarily due to hypoxia and ischemia, but a multitude of other origins. Again, neonatal encephalopathy has emerged as the preferred term to describe central nervous system dysfunction in the newborn period. The American College of Obstetrics and Gynecologists describes neonatal encephalopathy as a clinically defined syndrome of disturbed neurologic function in the earliest days of life in an infant born at or beyond 35 weeks of gestation, so not in a premature infant, manifested by a subnormal level of consciousness or seizures, and often accompanied by difficulty with initiating and maintaining respiration, as well as the depression of tone and reflexes. So ACOG further identifies intrapartum HIE as meeting these 4 criteria, but not all of the criteria can be determined right at the time of birth. First of all, the pH must be less than 7.0 or the base excess greater than -12. There must be evidence of moderate to severe neonatal encephalopathy. In the future, there must be evidence of spastic or dyskinetic cerebral palsy, and we must exclude other etiologies such as infection, meningitis, a coagulation abnormality, a stroke, an inborn error of metabolism, trauma, infarction, or other things. So we must investigate to make sure that there are no other reasons that the baby is encephalopathic. Again, looking at the etiology of HIE, or hypoxic ischemic encephalopathy, there are maternal reasons that can cause this. The maternal cardiac arrest, asphyxiation, severe anaphylaxis, if the mother is in status epilepticus, if she is in shock from hypovolemia, if there is a uteroplacental problem, a placental abruption, a cord prolapse, uterine rupture, or hyperstimulation with oxytoxic agents, and then fetal reasons, a fetal maternal hemorrhage, twin-to-twin transfusion, severe isoimmune hemolytic disease, or a cardiac arrhythmia can all cause hypoxia and ischemia in the fetus and during delivery. It is important to know about the antepartum risk factors. We know that, at least in the US, mothers that are poorer have a higher incidence of HIE in their babies, a family history of genetic problems, if a mother has had infertility treatments or thyroid disease. If she's had severe preeclampsia, any bleeding, any viruses, if there is a problem with the placenta or the baby is IUGR or postdates, or if there is defined chorioamnionitis. Intrapartum risk factors include an emergency C-section, maternal fever, an abnormal presentation of the fetus, and as we mentioned, things like a cord prolapse, a placental abruption, or uterine rupture. The gestational age plays an important role in the susceptibility of CNS structures to damage. We know that for a baby being hypoxic or ischemic less than 20 weeks in utero, the insult leads to neuronal heterotropia or polymicrogyria. At 26 to 36 weeks, so those would be our premature babies in our unit, the insult affects white matter, leading to periventricular leukomalacia. But for the older term babies, an insult affects primarily the gray matter and the deep brain structures. Other factors that influence the distribution of CNS injury include cellular susceptibility, so we know that in the brain, the neuron is the most susceptible. In terms of vascular territories, the watershed areas in the brain are at the highest risk. There is regional susceptibility, so those areas of higher metabolic rates, such as in the thalamus, are also at highest risk for being damaged, as well as the degree of asphyxia. And we can see the potential pathways for brain injury. We know with hypoxic ischemia, there's anaerobic glycolysis, there's a decrease in the ATP, an increase in the glutamate, increase in the lactate, adenosine is released. Going down this pathway, we see an increase in free radicals. Down this pathway, activating lipases, increase in free fatty acids, again with oxygen, free radicals, as well as activating the nitric oxide synthase pathway, again, an increase in the free radicals, which are very damaging to the neuronal cells. Acute HIE leads to primary and secondary events. The primary neuronal damage causes cytotoxic changes due to the failure of the microcirculation. So that is the first injury that occurs. This inhibits the energy-producing molecular processes. The ATPase membrane pump now begins to fail, and there is cytotoxic edema and free radical formation, which leads to compromised cellular integrity. And so that in the primary stage, or that initial period, there is the increased release and a decreased uptake of excitatory amino acids, the loss of ionic homeostasis across the membranes, decreased ATP, increased oxygen radical species formation, and activation of lipases and proteases. In terms of the secondary neuronal damage, that may extend up to 72 hours or more after the acute insult and results in an inflammatory response and the cell necrosis or apoptosis. And this is fueled by the reperfusion that occurs after the initial perfusion failure. So hypothermia that we use, the whole brain or body cooling, ameliorates or decreases this secondary neuronal damage. The primary damage has already occurred when the baby is born. We are hoping to prevent the secondary damage. When we have secondary energy failure, there's activation of the microglia, so there is an increased inflammatory response. There is activation of the caspase proteins, which triggers the apoptosis. There's a reduction in the growth factors or the protein synthesis, and there is further accumulation of the excitotoxic neurotransmitters. So our cooling cannot prevent the primary damage, but we can prevent or decrease the secondary damage. How prevalent is neonatal encephalopathy and HIE? In terms of developing countries, such as the US and developed countries such as the US and Panama, 3 to 6 per thousand, and HIE is about half of that at 1.5 per thousand. But we know worldwide, HIE is responsible for 23% of neonatal deaths, a huge problem worldwide. In the US, the highest risk are males, blacks, and low socioeconomic status. Again, in terms of the sentinel event, HIE, abruption, cord prolapse, uterine rupture, for all neonatal encephalopathy, it is only responsible for about 5 to 10%. But if there has been no sentinel event, when is encephalopathy due to HIE? So when would cooling be appropriate? And it has been hard to get a definite answer. We know when we look at a population study of neonatal encephalopathy, antenatal factors are the highest. There is some HIE alone. So again, the proportion due to HIE is much smaller than we would expect. But when we look at brain MRI studies of neonatal encephalopathy, the majority is due to acute hypoxic ischemia. So why is there a difference? When we look at population studies, the antenatal factors are the most important, and a very small proportion is due to hypoxic or ischemia. But when you are looking at MRI studies, this is a baby that is already sick. So intrapartum hypoxic ischemia is very common in the babies in which you get an MRI in the first days of life. So again, we're comparing different things, and most population studies don't include the MRI data. Looking at some of the systematic complications of HIE, there is acute kidney injury in up to 20%, myocardial dysfunction and hypotension in 28 to 50%, liver damage in 80 to 85%, and very common to have coagulation impairment or abnormalities in those that are severely asphyxiated. So it is important to address all of the other organs in addition to the brain. So it's important to maintain glucose levels, treat the hypotension, treat myocardial dysfunction, the coagulopathy, monitor the kidneys and liver function. To talk about seizures, it is important to treat them as soon as possible, obtain an EEG if feasible. It is important to monitor for subclinical seizures, since we know the vast majority of seizures that we see on the EEG are subclinical. We also want to make sure we treat other causes of seizures, such as electrolyte abnormalities or hypoglycemia or infection. There's controversy about the use of AEG. Some centers find it very helpful for continuous monitoring, and some centers more and more have the ability to do a continuous EEG or video EEG where the neurologist can view the studies remotely, but the baby is continuously hooked up with the 12-lead EEG. Moving on to hypothermia treatment. 1 hour later, the fluid boluses were given, hypoglycemia was corrected, and fresh frozen plasma transfusion was started. Baby started to have some spontaneous respiration, and the movements and tone improved. So we're happy. What would your next treatment plans be? To start hypothermia treatment right now? Obtain brain studies to confirm HIE damage if possible before starting hypothermia? Or since the baby is getting better, continue monitoring. And if the baby gets significantly better, we would not start hypothermia. So which of you think A is right? Which of you think B is right? And which of you think C is right? The answer is, for sure, you should start hypothermia because you have already documented severe encephalopathy. Even though the baby is improving slightly, you do not wait. You can go ahead and start hypothermia. If it is possible to get brain imaging, you should do so, but do not delay the hypothermia to get that. So the diagnosis of neonatal encephalopathy is a clinical diagnosis with a careful history and neuroexam, and again, ruling out other problems that could cause encephalopathy. Neuroimaging is the key, and there are 3 different modalities available for neonatologists. We can get a head ultrasound, we can get a CT scan, a CAT scan using radiation, or an MRI. And we want these studies to help answer several questions. What is the diagnosis? What is the prognosis? And are there more tests I need to do? So for HIE, a cranial ultrasound is not very good in assessing abnormalities in term infants. Echogenicity develops gradually over the first few days. So for that first day, it's not the best study. A CAT scan is less sensitive than an MRI for detecting changes in the central gray nuclei. So currently, an MRI is the most appropriate technique and is able to show different patterns of injury. The presence of signal abnormality in the internal capsule later in the first week has a very high predictive value for abnormal neurodevelopmental outcome in the future. So again, a head ultrasound may detect basal ganglia and thalamic injury, but is not sensitive for the cortical injury, which can also occur. It's very good, however, for detecting strokes and intracranial bleeding. The CT scan can detect diffuse cortical neuronal injury, But again, it's much better for strokes and hemorrhages that require immediate surgical intervention. So again, MRI is a study of choice for assessing hypoxic ischemic brain injury, and it provides information about the pattern, severity, and evolution. But again, neuroimaging is not a requirement for initiating hypothermia for HIE. So again, just the pros and cons. The pro of MRI is high resolution, there's no radiation, and it is the best for predicting outcome. The con is that NICUs usually don't have an MRI in their unit, so the baby needs to go away. The scan can take a long time. The baby may need to be sedated. Where does the injury occur in HIE? There are several areas. So there generally is in diffuse hypoxic ischemic injury, cortical injury, there is injury in the deep structures, and there can be diffuse white matter injury. Again, this is due to the oxygen poor blood in these areas, but cortical and deep are the major areas. So we can see the cortical injury that's occurred here and the basal ganglia injury that has occurred here. And you can see the abnormalities here. So again, the basal ganglia is seen in 74%, abnormalities here. And it can be unilateral or bilateral, anterior, posterior, or both. So seeing the abnormalities here. So again, comparing a normal MRI, you can see the normal posterior limb of the internal capsule, which is not present in deep gray injury, and then there's also some white matter injury in this patient. If you get it too early sometimes, though, you can miss it because the T1 doesn't show any diffusion abnormality, and you may need a better study at 4 days or 8 days. So again, an early MRI may be more helpful for the timing of injury. You see abnormalities about 24 hours, and if you see something sooner than that, something probably happened prenatally. And a later MRI will show you the full extent of the injury. So you've talked to this baby's father and explained to him that the baby is critically ill and may have suffered serious brain injury. So again, looking at the hypoxic ischemic injury, primary death, cytotoxic, and delayed neuronal death. And you can see that we're trying to prevent this injury here. So hypothermia has become the standard of care. Whole body cooling and head cooling are available. Gracias. It is not clear whether one regimen is better than the other. It is whatever you have at your institution. And the aim is to get the core temperature to 33 to 35 degrees for 72 hours. So let me go over these criteria. You need to have both the physiologic and the neurologic criteria. First of all, the baby needs to be greater than 36 weeks. Some centers will do 35 weeks, and greater than 1,800 grams, meet both physiologic and neurologic criteria, and no lethal chromosomal or congenital anomalies. To start with the physiologic criteria, the cord or baby's ABG less than an hour. If it was less than 7 or the base deficit greater than 16, the baby meets physiologic criteria. If there was no blood gas, or it was between 7.01 and 7.15, or the base deficit 10 to 16, plus you have evidence of a major perinatal event, fetal heart tracing, non-reassuring, cord prolapse, rupture, abruption, hemorrhage, bad APGARs, or you needed positive pressure ventilation, that meets physiologic criteria if the blood gases were not so severe. So you meet either this side or this side, and the neurologic exam criteria, 3 of 6 findings
from either moderate or severe. So there can be a combination of both of these. As long as they meet 3 of these criteria, they meet the neurologic criteria. So if you have physiologic and neurologic, or if there are seizures, they automatically meet the neurologic criteria. They are a candidate for cooling, and you should start cooling. Again, to remind you to do that physical exam for neurologic. So how does hypothermia work? It reduces the cerebral metabolism and prevents edema, decreases energy utilization, reduces the cytotoxic amino acid accumulation, inhibits the platelet activating factor, and stops the inflammatory cascade, suppresses the free radical activity, and stops the secondary neuronal damage, inhibits cell death. So we do know that death or severe disability at 18 months is significantly decreased. It's not effective for every baby, and it must be started within 6 hours of birth to be effective. And make sure that you do not let the baby become hyperthermic, which causes worse outcomes. So again, here's the whole body and the brain cooling. But even in the best studies, controls compared to cooled, there was still significant death or moderate to severe disability and cerebral palsy, even with those cooled. So it is not a 100% treatment. And we know that cooling from meta-analyses has improved outcomes. Does have some significant side effects like hypotension, arrhythmias, mostly bradycardia. There can be some increased oxygen consumption, some pulmonary hemorrhage, but no significant events have really been reported. We were wondering, is longer or colder better? There was a recent study looking at going down to 32 degrees or 120 hours. And the bottom line is more of the infants had worse outcomes if they were cooled longer or colder compared to the standard treatment of 33.5 for 3 days or 72 hours. So we do not recommend colder or longer. And just to quickly mention some new treatments: anticonvulsants, phenobarbital, other anticonvulsants, xenon, magnesium sulfate, anti-inflammatories, growth factors, stem cells, and just to then finish up quickly mentioning erythropoietin. There's a study that just came out this month on high-dose erythropoietin and hypothermia for HIE, a phase 2 trial. So this was a double-blinded, placebo-controlled trial giving high-dose EPO, 1,000 units per kilo, or placebo at 1, 2, 3, 5, and 7 days. These were all babies that had moderate to severe, and the primary outcome was neurodevelopment. And the neonatal deaths were not very different. The brain MRIs were improved in those babies that received EPO, and moderate severe brain injury was improved in those that received EPO than the placebo group. So we do think high-dose EPO or erythropoietin may prove promising, and in the US and in the world, there are studies ongoing looking at high-dose EPO. And the neurodevelopmental outcome was better for the babies that received erythropoietin. So to finish, the best patient care depends on close communication with the family, even considering withdrawal of support, multidisciplinary care, and working closely with neurology, radiology, and afterwards, physical and occupational therapy. Thank you.